up, we have JJ Ewing from ShiftMed.
Hello, everyone. Happy Friday. So nice to be with all of you. Some amazing, very different and unique presentations. So excited to be here today. I've heard this a couple of times about being an old nurse. I am an old nurse. I've been a nurse for over 32 years, but I was in bedside. I did nurse manager roles in the ICU, and then I moved into the workforce. So I've been in workforce industry side for about 25 of those years. I did 3 startups, so the entrepreneur in the room, very kudos to you. And one of which was a per diem staffing company back in the 90s, where we used beepers and we used faxes. We didn't even really have emails. We had a big whiteboard where nurses would come in and put their availability on, and when you'd cancel, you just erase them. So the technology was not there at that point. And then I went to AMN, a large travel company, and then I've been at ShiftMed for about 1.5 years. And I feel like I'm back home because what I'm doing now is really providing that per diem staffing again, back into our workforce strategies. So what feels old is new is really what used to be the tip of the spear. Per diem nursing, and we call it a bunch of different things now. We call it gig staffing. We call it registry nurses, per diem staff, on-demand staff. It's all the same concept. It's community-based clinicians working together to, well, thank you. I'm all done. No. Really tapping into that community-based clinician. And I can run it from here if you need me to. You want me to run it?
Is this the first one?
Yeah.
Okay. Can you try? No? Okay. Yeah, we'll cut.
There we go. There we go.
Okay, thank you.
All right. All right, so looking at how do we, we've heard shortages. We've heard, that's not new, right? Florence Nightingale had shortages back in her day. We hear about work-life balance and we hear about burnout. These are all not new concepts. But what has really been propelled in our time since COVID is the travel, the transient type of labor support. So we're really looking at going back to the community-based model, looking for providing flexibility to our staff, providing efficiencies with our operations, and providing resilience and stability to maintain a workforce strategy that can sustain a margin, quite frankly, today. Well, one thing that I've noticed in my many years in the workforce is that the transition in about 2015 with technology, MSPs, VMSs, really propelled travel nursing ahead of per diem staffing. Then and then of course COVID happened and travel became, crippling to organizations. And so, but the technology was not there with the on-demand or per diem staffing. So we are seeing this now, the ability to put that back into our strategy, that additional layer back in. And what is fascinating is the shift in the generations. I know everyone here has to deal with multiple generations every day. But what was really impactful was the fact that nurses over 55 years old and greater used to make up 50% of our workforce. Now it's down to 18% in just 5 years. So we see the millennials and Gen X, of course, are the main component, and then the Gen Zs, 1 in 5 nurses. So what does that mean for us? It means work-life balance. It means they want to work when they want to work. They don't want to be in these restrictive hourly models, 312s every other weekend, night shifts to start off with. They want that flexibility. They want the gig. And so where we find that flexibility, it's really not a perk anymore. It's more of a demand for these generations. And so we really are looking at prioritizing those needs. And so what I do on a daily basis is consult with organizations to help bring that flexibility back into the day-to-day. I have nurses sometimes that want to work 5-hour shifts, and you're like, are you crazy? How do you fit this into our schedule? But these are the things that are under, that are really being demanded by the generation in the workforce now. And so workforce shortages, again, the shift, they're unavoidable, but clinicians increasingly seeking that flexibility is mission critical. And how do we help to provide flexibility to our clinicians? We tap into those community resources. We provide app-based technologies that allow them to pick up like an Uber ride. And how do they do that? Very easily and in a very nimble type of technology. Not only does that provide clinicians control over their schedule, opportunity to work when they want to work, and they're all working full time. They just want to work when they want to work. And so this is really respecting the clinicians' needs. Now, what we also are doing is we're putting that technology in the hospitals, and we're saying, let's white label this technology and let your internal staff have the same level of flexibility. So anyone here from UNC? Okay, so we're working, are you ambulatory by chance?
Hospital at home. So
Okay. So, perfect. Okay, so we work currently with UNC Health, and they had 250 clinics, so we worked in their outpatient. They have urgent care centers, ASCs, physician networks, and they had 350 staff, so they were well staffed. They just couldn't organize the staff well. And so they were picking up about 40% of the open shifts in a monthly basis, which left 60% to go in contingent or in overtime or premium. We put an app in place that allowed them to pick up shifts self-schedule, and they went from 40% to 80% capture in just 3 months. So not only did it create a lot of cost savings because we stabilized the premium dollars, but it also increased their employee engagement scores. So we talked about that a little bit earlier. So it made them much happier, made them much more flexible. And guess when the time when people pick up shifts the most frequently? It's not at 6:45 in the morning when you're calling and begging them to come in. It's 11 to 2 a.m. at night. So they're going to bed, getting ready, reading a book, and they're picking up shifts coming up for the next day, the next week. And so we're really trying to accommodate that flexibility and allow them to really be in control. And so not only is it from a community perspective and those on-demand community resources, but internally as well. So we've seen a ton of success there. Again, operational efficiency, the ability to really balance out those labor costs. So, we've seen a really big reduction in travel. So every time I talk to an organization, they're like, oh yeah, we're down from travel. We got 10 travelers, That is great. But what is happening is the pendulum is swung. It's going over now to internal premium labor. So we're seeing bonuses, incentives, lots of overtime. We're seeing a higher burnout rate. We're starting to see those metrics tick up where people are starting to leave and go outside of healthcare. And so the ability to balance out that workforce is mission critical. And that's where we start to see bringing in these W-2 community-based resources, from CNAs to sitters to RNs to LPNs, all the way to allied, x-ray techs and all of these allied health positions. And so if you bring in those community resources, they come in at a much lower rate because they're not traveling, they don't have their housing and travel expenses, so they come in at a much better rate, and it really stabilizes and really reduces costs from an internal, external labor perspective. So really putting people back into the process, but CFOs love it because it actually reduces the cost in the bottom line. Any questions so far? I don't want to wait till the end. If you guys have any questions or comments, just please interrupt if you want to. Again, we're really looking about putting the people, purpose, and process back. Before we didn't really have the innovation. Now we have the technology to really make this flexibility happen. So building sustainable resilience. So as we had talked about, we're really looking at how do we manage the workforce now in a very sustainable option, putting the layers of flexibility that our generations are demanding, but also being fiduciarily responsible and making sure our costs are reduced and that we're not paying too high of premium rates. We have so many areas of influx right now where we have the big beautiful bill, we've got inflation, we've got so many pieces that are really tugging on the finances of healthcare, specifically the Medicaid cuts. So how do we find and capture some cost savings? It's really by using your community-based resources. One of the things we do with our on-demand staff is we convert them for free. So it is an opportunity to really build your core staff by test driving these clinicians. So somebody comes in for a short-term assignment, you get to test drive them and see if they're a good culture fit. Do they get along with the nurse manager? And then, of course, the facility gets to test drive them as well. So it gives them a really good opportunity to make sure the fit is good. And our attrition rate on conversions is about 2%. So they all know what they're getting into, so eyes wide open. So it is a really good lever of building a sustainable workforce strategy. And again, that community strength, I get this a lot where they say, well, you know, gig workers, they may not be high quality, they're just coming in shift to shift. Really isn't the case. Our community staff are some of the most engaged staff. They may be getting care at the facility. Their kids might play soccer with your kids. They're extremely engaged. We work with a hospital system in St. Louis called SSM Health. I don't know if anyone knows of them. 24 hospital health system over 4 states. And I actually have a case study here as well. But they did a clinical study. So they had not one on-demand per diem gig solution in place. And they had over 1,500 travelers in 2022. So in 2023, they committed to reversing the travel and putting it on demand. And what happened during that year was really amazing. They were able to tie quality metrics to the change of having travelers, very high traveler rate, to then having a very high on-demand rate. Their CAUTIs went down, their class fees went down, and their patient falls almost went down by 60%. So the community resources are much more embedded in caring for their community patients. So it's a fallacy I hear quite often, and so I'd love to dispute that one for sure. So again, foundation, stable workforce, how do we build that? By going back to what's old school, and that's the per diem staffing. This is the case study with SSM Health. Again, flipping the script, very, very high travel. I think they spent $180 million a year in travel post-COVID. And so when we went in 2023, we slowly started to reverse that travel reliance. And what we did to date, we've saved them about $130 million by putting technology layer in, by bringing community resources in, and by building a community and facility float pool of over 3,000 staff. So right now they have about 90 travelers across their whole system, 24 hospitals, but they have the largest float pool in the country. It's about 3,000 staff members, and that's a combination of both community resources and their core resources. Also along the way, they developed levels of multiple tiers of PRN. They put in a float pool. They did, so they added those flexible layers internally and leveraged the technology to manage that. Because what happens that we see now is, this core scheduling systems work really well for core schedules. The 312s, the other over the weekend, your holidays, that type of thing. But when you balance that schedule initially and those open shifts start to open and you have the PTO and the call-offs, those shift management goes into spreadsheets. It goes into a very manual process. I was at AONL last year, and they estimated 60% of a nurse manager's job is managing those open shifts in the day. And so they need to get back out on the floor. They need to start managing their staff, start working on quality metrics. And so the technology is, and the innovation is really allows them to get to that point. And then we did 1 million care hours last year there, so it was a very exciting. On the right, there's the conversions. We've converted, actually to date, we've converted about 720 nurses to full-time positions, and we've got now over 3,000 staff. So key takeaways. So a few principles. Really, the core principles of healthcare hasn't changed, only the tools. So the old school per diem model, use it. Take advantage of those clinicians. They are really wanting 95% of our on-demand staff, and we have about 450,000 across the country, W-2 staff, want flexibility. 95%, that's what they want, flexibility. A lot of them are exiting the healthcare, and they come back and teeter and say, you know, I want to put my toe back in the water. So a lot of those older nurses that want to, you know, work on their own terms. So really tapping back into that layer of support that we've sort of put to the wayside. Flexibility is the new foundation of stability, whether that's through technology, managing internally, or if it's you're using your external layers of support. That flexibility, that technology is mission critical. AI, I know you hear it all the time, but the tools are needed to free up those nurse managers, to make your staff happy, to increase retention, to allow for recruitment. All of these levers are part of that strategy. And then listening to clinicians is still the smartest innovation. There's nurse entrepreneurs. The nurses really get it. We get it. We know what needs to be done. And so really keeping that in mind and using them, having those nurses in the boardroom, making sure that they're the ones helping to make some of these decisions. And then the local staff, they're loyal, they're connected workforces build sustainable systems. And then the future of workforce innovation is really a return to balance. So people, purpose, and progress, and then I would add innovation to that as well. That's it. Any questions or comments or anything? Yes.
So for your per diem staff, can you, and I realize that it's different system to system, but can you talk a little bit about the different requirements that you require that you've seen required for per diem staff? Sometimes it's once per pay period or because I was looking at your slide for SSM because they said they worked 9 shifts a month.
Yeah.
Which seems a little high for some per diem staffing, which leads into sort of the second part of my question, which is keeping them up with, say, changes in policies, procedures, and innovations within the health system itself. Sometimes per diem staff, which is
Great
something I
question.
struggle with working per diem myself, that it can be difficult to keep up with some of the policy changes and innovations within the health system if you're not there as the full-time staff. Absolutely.
Really good question. So I'll address the second part. So within the technology, which is an app, we really try to keep it frictionless. We even have an I-9 form in there. We call it the credential wallet. Imagine having your ACLS card, your license, everything on your phone where it's very easily accessible. That's what we do. We also have an LMS system. So what we do is we capture our organization's, whatever their policies are, we continue to provision them. We do, and they are our employees. So we are working, they have their annual competencies, they're doing their annual reviews. So we have a very robust nursing compliance team that keeps all of them in line and makes sure they're at the utmost quality of standards. But the hospitals bring these guys in under their wing, and they oftentimes, if there's a class for, for COTIs or whatever the educational class is, they really bring them in as their own because these nurses are really felt and integrated into these units very effectively. So that is the competency thing. About picking up shifts. Our average is about 9 shifts a month, but it's starting to creep up because we're starting to see more and more full-time. And again, not that 3/12s every other weekend type of rigidity, but those opportunities to work whenever they want to. maybe work 5 hours or work 7 hours or, some of those crazy shifts. But what we do is our account management team is really incentivized to keep them on schedule. And a lot of times to reverse travelers, if we have a unit that has a high level of travelers or high vacancy or high premium pay, we'll start putting in short-term assignments. So these local clinicians will work maybe for 5 weeks, then they'll work, 3/12s or whatever they want to work. So we really make sure that there's continuity of care is really the biggest concern, right? So,
Yeah,
good,
thank you, that's helpful.
good questions. Any other questions? Yes?
Do you offer those services for doctors?
Great question. We actually are starting. In 6 months, so in August, we are launching our APP. So we'll be doing nurse practitioners, PAs, CRNAs. And then in second quarter of 2027, we're doing physicians. Now, if there is and we're doing this at University Health in San Antonio, they have about 600 physicians in their practices that are employed. So what they're doing is they're using our technology to schedule their open shifts. Because literally before, they had a piece of paper, literally, and they would write their hours and they would hand it in. So they're now working with the app to schedule their shifts at the urgent care, or at the, family practice office. So we're able to do that if they're employed, but we'll be actually recruiting and having them on our payroll in the next 6 to 12 months. Oh, great question. Yes?
What is the typical onboarding process? Like, how long orientation?
Yeah, great question. So what we do is usually mimic the travel, which is oftentimes a lot longer than really is needed. So we're working with organizations. They have the hold, it's like a baby with a blankie. They have these hold of these travelers so tight, they don't want to get rid of them, or the process. So the orientation, our staff, 5 years or greater experience is 80% of our staff. 50% are 10 years or greater, so super experienced staff. So they can really hit the ground running and in the specialty areas that they're at. So a lot of times it's they'll do a buddy shift, or they'll do an HR day, and then they'll do a buddy shift, and they can go out on the floor. The shortest one I've seen is a 4-hour HR, 8-hour buddy shift, and then the next shift they pick it up. And it's, there's been, there's the shorter the orientation because of their experience, and as long as they're checking off all the boxes, doing all the LMS, doing all the modules, they're really good to go because they're super experienced and seasoned.
And do you require them to have onboarding competency done?
Oh, yeah, we have actually, yes, we do. And we do it down to specialty. We work with Shiners. We have a pediatric burn skills checklist, self-assessment, that once they go into orientation, it has to be validated by their buddy or their orientee. So it's we're Joint Commission certified, so we have a very, robust and particular team in our compliance that really works hard to make sure everybody is very highly qualified and in quality. Any other questions? Yes.
So very interesting, your dynamics and studies. I would be interested to see how your studies look across what I am seeing now in home infusion.
Yeah.
Is we are getting a lot of those burned out nurses, which she had talked about.
Yeah.
And mostly it's, I would probably say your millennials who are still childbearing and they have childcare issues. So we're
Yeah.
seeing them leave and looking for more appropriate mommy hours to spend more time
Mommy
with
hours.
families.
Yeah, I love
So,
that.
I would be curious if you guys do a study. I am all about that because I see it and I
Yeah.
can't study it, so I'm like, this is interesting.
Yeah.
So I would be curious if you guys come out with that to
Well,
see if it accommodates.
We started in home care. That's how we started. So we, at our founder's parents, they couldn't find care. So he created this app to help curate that care. And so we started in home care, went post-acute SNF. But I do have some case studies. So if you have a card or something, I can share that with you. But we love our home health partners.
Awesome.
Perfect. Anybody else? Yes.
don't know, I think for nursing could be a really great thing, and for our patients as well, but I wonder how you see that impacted, like,
So I think that what's gonna happen is there's gonna have to be technology, right? It's about staffing plans and matrix, and they need to make sure that they're meeting those KPIs. So there's gonna have to be a technology layer added to make that effective. So we're seeing a little bit of a panic in trying to set those staffing, because again, there's so much going on in spreadsheets right now, so much going on in the manual process. I was at Cedars-Sinai a couple of weeks ago, and the nurse manager had 3 pages taped together for her schedule, highlighting. I mean, this is just part of our days. So there's gonna be a very immediacy needed to get technology in to make sure that they're meeting all of those requirements. And it's gonna get more involved. They're being gentle now with this first phase, but it's gonna really ramp up here, all around staffing in the next couple of years. Good question. All right, thank you.